Hello and welcome to the second instalment of a special series of interviews recorded as part of Intellect's In Conversation podcast. These episodes focus on contemporary general practice, and the series is brought to you in collaboration with two practicing GPs, Doctors Rupal Shah and Jens Foell. Rupal and Jens are the authors of Intellect's sensational new volume, Fighting for the Soul of General Practice, The Algorithm Will See You Now, a book which discusses themes affecting general practice, including industrialization versus craftsmanship, the effect of protocol, and the breakdown of relational care. On today's episode, Rupal and Jens are joined by Dr. Rowena Christmas. Dr. Christmas is the practice safeguarding lead and the managing partner who is responsible for clinical governance and quality improvements at the Wye Valley practice in Wales. She is chair of the Royal College of General Practitioners in Wales, as well as being vice chair of the Welsh Medical Committee. The focus of this episode is trust and the therapeutic alliance in general practice. Thank you for listening. We hope you enjoy this episode. Really glad to be continuing this series of podcasts focusing on our book, Fighting for the Soul of General Practice. And today, want to talk about something quite specific. It's, I think, a term that's often cited, and perhaps people, out there, our readers and listeners might not necessarily know exactly what it is. So, therapeutic alliance. I wanted to start by asking each of you how you would define what constitutes the therapeutic alliance. Rowena, can I start with you, please? So, what is this therapeutic alliance that we often hear about within the context of general practice and healthcare?
Well, I think I became a GP trainer about 3 years ago. I've been a GP partner for 25 years, so I've been practicing forever, really. But it wasn't really until I became a trainer that I started to become really aware of just what this therapeutic alliance is. I think it's just about really working in partnership with your patients. So, I've been to medical school, I've passed my exams, I've got my own level of knowledge and expertise. But the patient who's sat in front of me, they're the experts in their life and in their illness and in the things that really matter to them. So I think for my advice to be effective and for the patient to be able to make best use of the relationship they have with me, I need to make sure they're fully informed about all the pros and cons of, say, a medication I might be suggesting, or whether they need to go to the hospital. They need the information so that they fully understand, and then we work together to get the best outcome for them and their lives. And if we get that right, then they're much more likely to take their medication or go to the hospital or comply with treatment. And they're also much more likely to trust me. So everything just works a lot better, and we're going to get on better as well. So when you get it right, it's a really beautiful thing. I don't know what the others will think. They may have a slightly different take on it.
Well, Ru, how about yourself? What do you think? Does that align with your own beliefs?
Yeah, I know what Rowena says really resonates with me. Similarly, I've been a GP in the same practice for 20 years or so. I kind of think that as humans, our identity, who we are as people, is shaped through dialogue with other people. And I think when that dialogue is disproportionately centered around health, patients, especially those with multi-morbidity, mental health disorders, can become really reduced and kind of made helpless by us as a medical institution. And I think what a therapeutic alliance does is allow a broader view. It kind of permits people to be seen more fully and for their own internal capacity to be harnessed.
Jens, can I bring you in on this question as well? What does TA, therapeutic alliance, mean to you?
In the beginning, I think it's a utopia, something you aspire to, but nothing that is static over time. So I'm a bit more skeptical about it. I think it's on and off, and maybe like a long-standing relationship, something where at times there's conflict and it's not happy ever after. The baseline for me is trust, and trust as a method of complexity reduction. And that works particularly well and is necessary for complex situations, mental health, multimorbidity, a lot of social asymmetry, chronic pain. That's where nothing works without the therapeutic alliance, because then you get all the friction, the nocebo factors, the fragmentation, the reduplication, etc. So the baseline is trust, and a lot is needed in terms of relationships and organization to make that happen. It's not something that happens and then it's there ever after. It's something that has to be regained, and two people need to want that.
Well, I just want to bring in Ru here. I think Ru, you might have something to say on this topic.
What you say about trust, I think, is very true, Jens. And for me, one of the things that blocks the therapeutic alliance is a kind of lack of authenticity, because there can't be trust in that case. So I've been interested in this idea about artificial persons. I don't know if you've come across this term. I think Thomas Hobbes first talked about artificial persons in his Leviathan in the mid-17th century, sort of meaning people whose words and actions represent the institution to which they belong, rather than being authentically their own. And I think that from a GP perspective, it's very problematic when we behave as artificial people who are representing the NHS as a whole, rather than being kind of genuinely ourselves. So for me, a warning sign is when we start using the pronoun we instead of I in situations when it doesn't make sense. For example, we would recommend that you take a statin for your high cholesterol. Well, sorry, we don't refer people for the condition you have. It's a kind of variation, I think, of computer says no, which for me is really antithetical to a therapeutic alliance, because how can you trust someone who's behaving as an artificial person and not as themselves? Be interested to know what people make of that.
Yeah, Rowena, what do you think about that? Is there anything you'd want to say?
I love what Jens said about trust is a method of complexity reduction. I mean, that I'd never thought of it like that, but it's so true. And somebody said to me once, trust comes on foot but leaves on horseback. And you know, we are constantly holding this fragile connection with our patients. And I've found, and I always say to the students, you know, whatever you do, be absolutely honest. You know, if you're suggesting a different medication because it's a little bit cheaper for the NHS, for heaven's sake, don't dress that up as it's you know, the same thing. And you know, be completely frank. And people tend to be happy with that. You know, they'll often choose a cheaper product in the supermarket, and if it doesn't taste as good, they won't try it again. And if you can be honest and say, you know, if it doesn't work, we'll go back to the original, people are with you. Whereas if you try and, you know, fob them off, people are super smart. You know, they can see through anything like that. And Ru's saying, you know, don't say we. You are you know, an independent clinician working for yourself. You're absolutely right. As soon as they think you're just doing what the health board or whatever organization sort of leads you is telling you to do, you've lost, really. And we had that with the COVID vaccination. You know, there was a lot of sense from some patients that we were in some sort of groupthink government body saying you must do this. And if you can get back to that sort of, I'm here and I'm on your side and I'm your GP, have been for years, I think this is the best thing to do. You can sometimes cut through that sort of fear and get to a sort of therapeutic alliance that is so productive.
Where did this language, this we, come from then? Has that just happened sort of organically, or has that been from the top down kind of thing? Because it sounds like it's a bit about semantics, language, and how we define things.
May I chip in at that point?
Please.
I observe it as a teacher educator for quite some time, at first with the students. And I thought, where's this we coming from? We do this, we do that. And who is this we? Is it a kind of millions of pixeled army of young doctors who always would do the same, and then you feel safe because you are surrounded by like-minded people? Or is it the dominance of protocol, which now a whole generation grew up with it in medical school, going through OSCEs, where we do this and that, and there's always a right and a wrong. And now you come out at the other side of a life where you get constantly assessed, you are constantly following rules. And if you're following rules and we are following the rules, then you are safe. And a little bit that protects you from the risk of not conforming with it, and from making individual arrangements with patients. And that is a risk because you're not there all the time. The system needs artificial people that would say, if you're an artificial person, job done, I should be so happy. The only problem is that is not good enough for dealing with real people with emotions, families, and so forth. So you need to be a cyborg, maybe half an artificial person, half a person who is able to make individual relationships and contracts, which is exactly what GPs do. Patient allegedly in the center, I doubt that. The protocol is in charge, but you have to, as a street level bureaucrat, straddle between where do I align with the organization, the protocols, also the money. If people go on this and that, you get a premium and you get paid for it. Or do I align with a patient who disagrees and so forth? So there's a lot of ethical aligning and prioritizing conflict in this journey from face to face to side to side.
And Rowena, I believe you've got your hand up here. Would you like to say something on this topic?
I agree with you, Jens, but at the same time, a protocol is just a protocol. You know, so long as we can justify deviating from it, and you know, in this litigious world, we when we deviate, we have to put loads of documentation down to justify why. But it would be a sad situation if we felt we were so locked into the sort of cyborg, we've got to follow the protocol. It would be a miserable job being a GP if you didn't have a little bit of flexibility and able to focus on the patient in front of you and what works best for them, because very often the protocol isn't exactly what that patient specifically needs.
Well, adding on to this and this notion of we in this topic as well, one of the questions I did want to ask was, with there being large multi-professional teams and the kind of the erosion of the traditional GP, or I think people at least have a sense of that, that this family GP, this idea, this concept has been eroded over the years. Is it actually possible for a patient to have a therapeutic alliance with a broader organization or a group of clinicians in this kind of modern multi-professional team environment that you're all working in, or is that simply just, you know, a non-starter? Ru, why don't you tell me about that? How do you feel about this one?
I think, James, it depends on trust, as Jens has pointed out. And so I think the culture of the practice, for example, is really important here. I think if you have a culture where patient-centeredness is not is important to create meaning with patients, where meaning is kind of embedded. You know, I think you probably can have a therapeutic alliance with a team of people if the team is aligned. I think the team has to be aligned in their own values.
Can I bring one of you, Rowena, Jens? Would either of you like to comment on this too? Rowena, please.
Yeah, I think Ru's absolutely on the money with the team has to be aligned. And actually, I think if the team is aligned, you know, if you're a really good, collaborative, cohesive team where you know everybody's going to do a good job and do the best for their patients. Actually, I think in that situation, the therapeutic alliance between the team and the patient can be enhanced and even better than if it's just constant GP always available and the patient. Because just like if you're in a meeting and you've got people around the table, different sexes, different religions, different colours, you know, you're bringing far more to the conversation, far more depth and understanding. So I know our district nurses or our Macmillan nurses will have huge amounts of knowledge that I don't have so much. So if they're all part of that team, the patient's actually getting a better job having a bit of each of us, and we're all talking to each other and making sure that we know what's going on, than if they only ever see me. So I think it can be a winner, but as Ru has said, if you're not all talking, it's not going to work. And certainly if you don't trust each other as team members and you don't know for certain that somebody's going to do what they say, everything will then fall apart. And I think increasingly in our very hard-pressed environment, that's what's happening to some teams, unfortunately. Can
I bring breakfast at that point? I come from a rehab background in Germany, and we didn't have as such a multidisciplinary team, action points, meetings. It was not that structured, but what made us a very functioning, well-organized team is that we had breakfast together every day, gossiping about the patient, making notes what we were doing, and that made us a caring team, more by the invisible trust we had into each other's. And that is something I'm longing a lot in primary care. It's very, very difficult to create, but you know when it's there, but you know even more when it's not there. And yes, patients can relate to the team. Of course, they would say a person, but the person is never alone. No man is an island. And therefore, the team is extremely important.
Is this myth of the kind of family GP, the lone, the island sort of thing, is that a myth? Has it always been a bit of a myth? Because sort of growing up, I just always remember going to see one doctor, and it always being one doctor who was delivering the diagnosis and the prognosis and all the rest of it. And occasionally you would see a nurse, perhaps. I'm just only referring to my own, of course, experience. Has that totally changed, or was that always sort of a mythologized small village kind of mentality? Because I was born and raised in a rural community in England, which may have impacted my understanding of general practice when I was young. And then since then, of course, I've moved over to the US, so I don't really know how things have changed in the practical day to day. But is this kind of this mythologized GP of the past a thing that exists or ever did exist? Is it reductive to think about GPs in that way, or has it always been more of a team dynamic anyway?
I mean, it depends where you are in the country. I have to say, in my own practice, that's very much what you've got, and there will be, all the people in my locality, if they think of a GP, they'll probably think of me, and that's who they've seen, which is fantastic for me. Probably not bad for them, But I think that's increasingly unusual. I think Jens may well have that up in North Wales. I don't know about you, Ru, what your practice is like, but there's increasingly practices are struggling to be, one or two doctors only, and there's a lot of mergers, and there seems to be a sort of government push for bigger is better, which I wouldn't necessarily agree with. So there will be many, many people in the UK who will never have experience that one doctor that they think of when they think of their GP, which I think is a bit of a shame.
Yeah, no, I think that's right. In London, where I work, there's a very transient population anyway. We're a big practice. And so I think really it is a myth. I do have a cohort of patients who mostly see me when they can. But really, I'd say of the 14,500 patients who are registered with us, not that many of them would think of one particular GP as their own doctor, which I think is a shame, that that's the reality.
I think from a hospital perspective is certainly a myth. Back to GP, nobody will write a discharge letter thinking you go to a very diverse organization that is fragmented and it has lots of other disciplines, lots of creatures with clipped wings whose actions need to be rubber stamped by somebody else who didn't deal with the case. Nobody will say that. So everybody assumes there's this mythological figure, a GP who does home visits, has always time to do home visits. Can you do this? Can you do that? Has always time to titrate medication up, do ECGs, and so forth. So in this sense, it is a mythical, endless loving, endless capacitous figure, and not an overstretched organization. Nobody would say A&E, back to A&E, thinking A&E will do that. So A&E is allowed to be impersonal and overwhelmed, but a GP is a person who has to do something and who does background work. As an industry, I think there's extreme heterogeneity amongst the country, from 40,000 or 90,000 people organization to single-handed GPs who might be in an impoverished part of Bristol or London or island doctors, group practices, but you cannot assume that there is an 8-session, 10-session plus a home visit doctor who is enmeshed in the community. That is probably a figure from the past.
Well, thank you all for those answers around this idea of therapeutic alliance. Just, I guess, finally on this topic, do you think it, as a term, as a way of thinking, it's practical and useful? Do you like it as a way of thinking? Do you see it having an important place in the future in terms of conversations around general practice?
Yeah, I absolutely do. And I think I said at the beginning, it's one of the things I talk an awful lot to my medical students or foundation year doctors or GP trainees all the way through. You are more effective as a doctor if you can win that trust early on. And that's what we want, isn't it? We want to spend our time usefully, and if you've got your patients' trust and they understand the pros and cons of the decisions they're making, it's much better for them, and it's probably much more cost effective for the NHS as well, which is really important because there's a finite amount of money and we need to really make sure that we spend it wisely. So if we refer somebody for a procedure that they never wanted in the first place, that's doing nobody any favors, really. So yeah, I'm a big fan. I think it's the sort of bedrock of what I am as a GP, I think.
So not smoke and mirrors, but a really practical way of thinking by the sounds of it.
Yeah, I'm going to be optimistic, and I think that maybe the therapeutic alliance, how we defined it, will become more and more important in the next 10 years, for example. I think we've got the advent of artificial intelligence, and if it's implemented in a values-based way, then it gives us tremendous opportunities. For example, it can take away an awful lot of our administrative burden. It can help us clinically, diagnostically. It could kind of flag up important points in the patient's story that we might not have remembered, abuse as a child or kind of similar presentations in the past, similar investigations. There's an awful lot of potential there that will free up time potentially for us to really try to engage with our patients to try and understand their context, what matters to them, where they would like to be, because I don't think we're very good at doing that now. I think we can be quite reductionist because of this, I suppose, craving for safety and certainty where it can't exist. We end up as a profession, I'm using the word we deliberately, meaning us as GPs, create harm by being reductionist, by following the protocol, by trying to be safe and disregarding our patients, what they want, what they need, what they're expecting. So I think, and I hope that the role for the Therapeutic Alliance will become a more important part of our work as GPs in 10 years' time.
Right now, I'm remarkably optimistic with technology. For example, one platform allows me to interact directly with the patient after the blood results. So there are a lot of, let's say, chat functions where one's trust is there and you're standing on the shoulders of giants. It's very, very nice to have both the ultra long and the ultra brief relationship. And I think that is necessary to deal with such complex situations. You need basic trust. You need to know the family, the location. Otherwise, it's extremely ridiculous what you're doing. And alienation is kicking in. You feel part of a horrible machinery. You check in and out, but that doesn't make anybody happy in the healing, helping profession that we are.
Well, thank you each for those answers. I think that's really useful, sort of investigating this idea of therapeutic alliance, which was a new kind of concept to me. So thank you all. But I do have one sort of last question I'd like to put to each of you today, which kind of leads on from something that Ruth said momentarily ago, really. Looking at the next 10 years, what will the role or the purpose of the GP become?
That's a huge question, really. I'm going to be optimistic, despite the fact that studies give us terrible statistics sort of suggesting that 48% of GPs don't see themselves still in the profession in the next 5 years. So we've currently got a real workforce workload crisis, and my gut feeling is it's only going to get worse. But despite that, we absolutely have to turn it around, because we've got an aging population, people living with increasingly complex, multiple sort of different forms of ill health that we are absolutely best placed to support them with. Right at the moment, we've got more people of working age not working because of ill health than we've ever had before. You know, there are really worrying things going on that we need very good community care to support our patients with. We've got to invest in the community, or the NHS is going to run out of steam, and it's not going to be sustainable. So I think if we can convince the people that make the policies and pay the money that we need to invest in the community, the whole multidisciplinary team in the community. So GPs, yes, our whole fantastic multidisciplinary teams, and district nurses, and health visitors, all of those people, then we will take the pressure off secondary care. We'll work on prevention. Everything will get a bit better. I pray that's where we're going to go. Talking to sort of young GPs, there's a terrifying sort of tendency for some of them not to be completely averse to the idea of private practice, which just makes my blood go cold, really. It feels a terrible prospect, because the health inequality problem, if we go down that route, is just going to get even worse than it is at the moment. So I hope we can convince the policymakers that the community is where investment is needed. And if that happens, I think we will be thriving in 10 years' time.
Well, thank you for an optimistic and succinct answer to what was a rather tricky question, but I think that's really useful kind of food for thought there. Thank you, Rowena. And Jens, could I have your take on this? What's the future of the GP's role looking like?
I really don't know. I think I'm like Don Quixote fighting the windmills, or something ridiculous driven by values and stubbornness, but I'm not sure whether that's a good political analysis. My feeling is that whoever works in primary care has to be very, very, very closely aligned with the carers, and the carers need to be better paid, financially better supported, also in terms of their status and their background, and then I think we have a chance. General practice is well placed to address this, because general practice has always been very flexible, adaptive, and I'm positive about that.
Thanks, Jens. Again, I'm glad to have another optimistic answer. Ru, can I get your take on this too, please?
The future could go either way, and it depends on what we determine for ourselves as a profession. I think we really need to have these conversations within our profession that I don't think we're having at the moment. What do we want to be? Do we want to be transactional kind of chatbot type doctors who are just providing information? Because that could happen, if that's what we decide as a profession. Or do we want the profession to be about proper engagement, authentic engagement with our patients, meaning making, nuance, personalized care, and what are the factors that need to change to enable that? Because there are structural things that would need to change, the culture would need to change. So I think it depends if we're brave enough and willing to have that conversation.
Thank you. Thank you each for those answers and for your time today. Rowena, thank you so much for joining us today. Really appreciate the time. And as I say, this is part of a broader series of podcasts that we will be continuing to produce throughout this year with my colleagues here, Jens and Ru. So thank you again for your time and for your contributions. And again, I'd just like to ask everyone to check out the book Fighting for the Soul of General Practice, which is of course now available to purchase from intellectbooks.com or from all good bookshops. Thank you again for your time. Wonderful to see you all today. Cheers.
Thank you all. It's been a real pleasure.